Welcome to Science Force. Let's dive straight in, shall we? Today, we're taking a definitive deep dive into the cellular mechanics of rhinitis. We're going to completely unpack the exact pathophysiological cascade that drives this incredibly common condition. Because to truly diagnose and manage this, have to master the microscopic battlefield first. So here's our roadmap for today. We'll quickly cover normal nasal anatomy, move into the pathophysiological cascade, explore the resulting physiological changes, break down the types of rhinitis, and finish up with diagnosis and management targets. Section 1. Normal nasal anatomy. All right, Section 1. Normal nasal anatomy. Let's just establish our baseline. Now, under normal circumstances, the nasal mucosa is honestly a beautifully engineered, highly efficient system. It filters the air by trapping dust and microbes in a moist blanket of mucus. It humidifies dry air and regulates temperature, warming cold air before it ever reaches those delicate lungs of ours. It gives us our sense of smell and, of course, provides robust frontline immune defense. Actually, a fun fact for you, your nose produces about a quart of mucus every single day just to keep this whole operation running. Keep these baseline functions in mind because rhinitis is the complete systemic breakdown of every single one of them. A vital part of that baseline function is the localized immune system. The nasal mucosa is packed with this frontline defense force, macrophages, lymphocytes, eosinophils, and very importantly, mast cells. I really want you to pay special attention to the mast cell. For the context of our discussion today, I want you to think of the mast cell as a ticking time bomb, just sitting there waiting for the exact right pathological trigger to set it off. Moving on to Section 2, the pathophysiological cascade. This is where we get into the microscopic mechanisms. Listen, for your board exams and, frankly, for your daily clinical practice, this cause and effect sequence is an absolutely high-yield concept. The cascade pretty much always follows these 4 distinct steps. First, there's exposure to a trigger, say pollen, dust, or a virus. Second, we see immune activation. That's when those mast cells and T lymphocytes wake up. Third, and this is critical, is the massive release of inflammatory mediators like histamine, leukotrienes, and prostaglandins. And finally, step 4, this chemical flood directly forces the physiological changes in the local tissue. Let's look specifically at allergic rhinitis to see how this bomb actually gets built. We call this the sensitization phase. When an allergen first enters the body, B lymphocytes start producing specific IgE antibodies against it. These IgE antibodies then go and attach themselves directly to the surface of our mast cells. Now, interestingly, the patient generally doesn't experience any major clinical symptoms during this phase. They feel fine. But underneath it all, they are now completely sensitized. The weapon is loaded. But contrast that with what happens next, the re-exposure phase. When that specific allergen enters the nasal cavity again, the IgE antibodies sitting on those mast cells instantly recognize it, and boom, this triggers an explosive reaction. The mast cells literally break down. They degranulate, resulting in a massive, overwhelming release of histamine and other inflammatory chemicals. It is precisely at this moment, right after degranulation, that the clinical symptoms violently appear. Which brings us to Section 3, Physiological Changes and Symptoms. Let's connect the microscopic to the macroscopic. So why exactly is your patient sitting in front of you complaining of a stuffy nose? Well, look at the cause and effect here. That massive histamine release causes severe blood vessel dilation and increased permeability. Fluid literally leaks out of the vessels and into the tissue, which gives you the clinical sign of severe nasal congestion and a runny nose. These chemical mediators also stimulate the local nerves, triggering a reflex arc that makes the patient sneeze violently and itch endlessly. And finally, they force the nasal glands into overdrive, churning out excess mucus that shows up as a clear, watery discharge and a really irritating post-nasal drip. When you're performing your physical examination, you've got to play detective. Your eyes must be searching for these classic clues. If you look inside the nose, you won't just see a red, irritated lining. Actually, classic allergic rhinitis often presents with a pale, swollen, almost bluish nasal mucosa. You should also look at the patient's face for allergic shiners, those dark venous pooling circles right under the eyes. And check for a transverse nasal crease across the bridge of the nose. That's the direct result of the patient constantly rubbing their itchy nose upwards in what we playfully call the allergic salute. All right, Section 4, Types of Rhinitis. Let's look at the clinical categories. The absolutely crucial divide here is the pathway. Allergic rhinitis is strictly an IgE-mediated immune response. It's an exaggerated, hypersensitive reaction to an allergen. Non-allergic rhinitis, on the other hand, can look totally identical in the clinic. The congestion, the runny nose, the whole shebang, but it absolutely does not involve an IgE-mediated allergy. Understanding this underlying pathophysiology is a game changer because it completely alters your management strategy. Now, within the allergic category, a careful patient history is by far your best diagnostic tool. You have to ask about the timing. Seasonal allergic rhinitis flares up very predictably during specific times of the year, usually triggered by outdoor pollens from trees, grasses, or weeds. But perennial allergic rhinitis, that's chronic. It happens year-round, and that points you directly towards indoor triggers like dust mites, pet dander, mold, or even cockroach allergens. Then, of course, we have the non-allergic variants. Here, abnormal regulation of the nasal blood flow is usually the culprit. We have viral infections, obviously, but remarkably, vasomotor rhinitis can be triggered by abrupt temperature changes, smoke, or, get this, even pure emotional stress. We also see hormonal rhinitis quite often during pregnancy or due to thyroid disorders, where hormonal shifts just increase blood flow straight to the nasal tissue. And please never forget drug-induced rhinitis, which is commonly caused by certain antihypertensives or oral contraceptives. Oh, and here's a fascinating and completely preventable phenomenon, rhinitis medicamentosa. This is an iatrogenic condition, meaning it's medically induced. When a patient excessively uses simple over-the-counter nasal decongestant sprays, the local blood vessels actually become dependent on the drug. When the drug wears off, the vessels dilate forcefully, causing severe rebound swelling. So what does the patient do? They use more spray, and a vicious cycle begins. Let's wrap things up with Section 5, Diagnosis and Management Targets. Let's tie it all together. Your diagnostic toolkit obviously starts with that meticulous history we talked about, but to visually confirm what your history suggests, we use the skin prick test. By placing small allergen samples right on the skin, we can actually see that localized IgE response happening in real time. It produces a classic red, raised, itchy little bump. We can also use blood tests to measure total and specific IgE levels, or take a nasal smear to check for eosinophils. If you see those, it strongly points to an allergic cause. Just look how beautifully these drugs map onto the cellular cascade we just learned. Cetirizine is an antihistamine. It directly blocks the effects of the histamine released back in step 3 of our cascade. Fluticasone, which is a topical corticosteroid, broadly calms down all that resulting tissue inflammation. Pseudoephedrine acts to forcefully reverse that leaky blood vessel dilation, which drastically cuts down the congestion. And montelukast works by specifically blocking leukotrienes, which, if you remember, is another key inflammatory mediator. Every single drug has a very specific microscopic target. But before we finish, let me ask you a really critical question about patient outcomes. What exactly happens when this aggressive inflammatory cascade of rhinitis is just ignored, maybe brushed off by the patient as a simple cold and left completely unchecked over the long term? Well, the answer is severe systemic complications. Chronic, untreated inflammation blocks up drainage pathways, which leads to recurrent sinusitis and painful middle ear infections. The constant nasal obstruction causes profound sleep disturbances. That leads to daytime fatigue and significantly reduced concentration, which can severely impact a child's schooling or an adult's career. It can even lead to the physical growth of nasal polyps. And crucially, unchecked upper airway inflammation consistently worsens underlying lower airway diseases like asthma.
Thank you for watching Science Force.